Hi everyone, welcome to the 47th session of Virtual Shadowing. Today's session is a specialty spotlight in radiology with Dr. Tiffany Chan. As always, you can contact us on Instagram at Virtual Shadowing or through our email, which is virtualshadowing@gmail.com. These sessions will be recorded and posted to our YouTube channel, which is Pre-Health Virtual Shadowing. Next slide, please. Here are our upcoming sessions. Tomorrow is our rescheduled PA spotlight in psychiatry. Next week, we have a specialty spotlight in GI and endoscopy. And the week after that, we have another PA spotlight in OB-GYN. Join us on Zoom or YouTube Live at 7 p.m. Central Standard Time for these sessions. Next slide, please. Here's the virtual shadowing working group comprised of Reagan, Shayon, Taylor, Rachel, Miriam, Elena, Ani, Kiana, and myself, as well as our 4 physicians, Dr. Fowler, Dr. Morchetti, Dr. Salazar, and Dr. Reno. Next slide, please. As always, we will have 2 Q&A sessions, one near the middle and one at the very end. If you have any questions, please put it into the chat. Don't direct message them to either me or Dr. Chan. If you have any questions about the assessment, please hold them until after the second Q&A. Just to remind you, this session will last for about an hour and a half to 2 hours. And with all that said, please welcome Dr. Tiffany Chan.
Hello, everyone. It's so great to see everyone virtually on this wonderful platform. Today, I'm going to talk to you guys about what it's like to be a radiologist. Specifically, I'll talk about my experiences in the academic setting, and I'll show a few cases and pathologies in the particular subspecialty that I have subspecialized in, which is breast imaging. So I have a few goals for you today. First, I'm going to share with you a little bit about myself and the journey that I took to get to where I am. I want to give you a general background kind of in radiology as the awesome field that it is. I'll show you a typical day in my life and give you an introduction to some of the different types of imaging that we deal with. And lastly, I'll show you some cases as well, where you can learn about some pathologies that we see and also learn about the procedures, the image-guided procedures that we do during our days. So let's get started. So I'm currently an attending physician on faculty at UCLA, which is considered an academic hospital, obviously. I'm considered junior faculty because this is about my second year as an attending. I finished my fellowship not that long ago, and this is actually my entire journey listed out for you in terms of how I've gotten to where I am. I'm one of probably the less common people where I've gone straight through from the start, meaning I didn't take any time off. I did a double major during my undergraduate years because I just always had a passion for writing, but I also obviously was pre-med at the time. I was lucky enough to get into med school the first time around. I went to Albany Medical College in upstate New York, a very cold place. Ended up staying there for my intern year, which, by the way, if you are a radiologist, part of your program means that you spend 1 year in what we call an intern year. That intern year can technically be in surgery, in medicine, or something in between that's called a transitional year, kind of a mix of both. You get to choose and you kind of apply just like you would for any other match. I chose to do surgery because I very much like procedures and I like the surgery sort of personalities that I encountered at Albany. After that year, I went to Penn State for my residency. That's diagnostic radiology residency. And then I went somewhere warmer at UCLA and I did breast imaging for 1 year. And one thing I wanted to point out too is that, at least in my experience, a lot of the people I met along the way ended up taking time off, let's say between undergraduate and medical school. There's no right or wrong way to do it. There's kind of pros and cons of both. Obviously, the biggest pro of kind of doing it the way I did was that my journey was not as delayed compared to other people. I was able to at least start making attending money a little bit earlier than later. At the same time, I probably didn't explore as many different types of careers that some of my friends did. I had a friend who was working in hedge funds, for instance, in New York before she came to medical school. So everybody's journey is different. This just happens to be mine. let's talk a little bit about radiology in general. I don't know how many radiology lectures you guys have had so far. So I'll kind of give a brief overview. So I think of radiology as a field that almost all the other specialties kind of depend on in some way. So everybody from primary care to neurosurgery, they all rely on medical imaging of some kind to help make decisions for their patients. We aren't covered a lot on medical shows, and when we are, it's usually a non-radiologist holding a picture upside down, okay? But while a lot of physicians are okay at reading their own specialties imaging, it's always our job to kind of pick up the most subtle findings and maybe the less common findings. So for instance, I know orthopedic surgeons can read knee MRIs fairly well. It is still our job as the radiologist to pick up on the more subtle findings that they may not find. Radiology is really reframing everything that you've learned in medical school in the form of pictures. So we need to know what's normal, what's abnormal, and sometimes the trickiest part is knowing what is a normal variant, meaning something that is not common in the general population, but is technically normal, and most importantly, does not need any further diagnosis, treatment, procedure, anything like that. The great thing about radiology too, in my eyes, is that it kind of represents the truth. Patients can lie, histories can be faulty, but pictures, can generally tell the answer. It's also great because radiologists, are staying on top of the latest technology. So some, let's say, of my older colleagues were well trained on X-ray and ultrasound, which are still very important nowadays. I'm learning a lot about MRI. In the future, there's going to be combinations of MRI and PET-CT. That's already happening at, MRI and PET at many institutions. So it's a really evolving sort of field, depending on what technology can help us do. When I'm talking about radiology, you may be like, okay, well, what are some examples here? So I just kind of created this table of the different specialties that a radiologist can specialize in. I'm obviously in the second row here in the breast section. And these are, some examples of some common studies that are read. So let's say a neuroradiologist is going to be the expert on reading things like a spine MRI or a CT head. Pediatric really covers a whole range of things for the pediatric population. I just gave some examples that you may heard of, X-rays and ultrasound for appendicitis, that sort of things. But there are many different specialties within radiology. And when I was a resident, I rotated through all of them. So we get a flavor of all of it. We take overnight call and that sort of thing, okay? Some myths about radiology that you may have heard. Some people may think that we aren't real doctors. It's actually very funny because we are the only group that's really considered the doctor's doctor. At least the old school mentality was that. And that's just because other physicians consult us for what we see and think about a patient's imaging. And in the same sense, we actually do see patients, at least some subspecialties of ours, including breast imaging and interventional radiology, which is kind of like a subset of radiology as it is. And in that sense, we are the patient's physician as well too. Obviously, we're part of the clinical team because we help make medical decisions. Some examples of that in the acute setting, if you were to work in ED radiology or emergency radiology, or if you're a resident rotating through, if a trauma was to come in, like a car crash or something, where I trained, the radiologist would go to the CT scanner. As they're scanning the patient live, we're kind of yelling out to the emergency folks, the surgery folks, anybody who's there, about all the different findings that we have. So like a kidney laceration, a vertebral spine fracture, all those things are kind of acute things that obviously a patient cannot tell you, but are very real findings. And some of them are, very crucial that we convey that quickly. Some other silly myths that I've heard too, that we don't like to socialize. I like to think that, our hours in general are pretty good. So we do have some time to socialize. We just don't do it in the hospital necessarily. And of course, radiology is not easy. It sometimes looks like it because we're just sitting there looking at a computer. But it's actually one of the toughest ones because, like I said, we kind of have to learn medicine from head to toe. So it's definitely one of the more difficult ones to intellectually succeed in. I just put in like maybe 1 or 2 slides in general about getting into radiology. Of course, step 1 and step 2 are basically our big exams that we take in medical school. That is changing, I believe, in January of 22. So these numbers may not mean as much to some of the younger folk, or maybe the majority of the audience, but just so you know, these numbers are above average. So when scores mattered, basically the ones that succeed in getting a radiology had fairly above average scores. It doesn't necessarily mean that much, except for the fact that it does help you get that first step into getting an interview. Besides that, radiologists or those wanting to go into radiology are very interested in doing research. They tend to do well on their rotations. These are just kind of like a general snippet from one of our big programs, the AUR. So just some interesting information. And so the old school way of thinking about radiology is the road to success. I don't know if you guys have heard about this. And this is traditionally the 4 specialties that offer the best compensation and lifestyle. And that's kind of like overall work-life balance. Now, I want to point out that compensation is only part of the overall lifestyle. If you don't like what you do, it doesn't matter how much you make, okay? Because you have to feel fulfilled at the end of the day in order to have a lifelong career. That being said, it's not really discussed among pre-meds or med students, the financial aspect of what you're doing. And it does have a practical significance. I'm still paying off my loans. When I finished the total, I had, about 300,000 in loans. So this kind of stuff was a little bit practical. All I really want you to take away, I think, is probably this slide, this section here. I would choose the same specialty at the bottom left-hand corner here. And that's really important to me because radiology is ranking pretty high in the group of people that, Medscape has surveyed. And we generally would choose the same specialty, which I think is really, really important when you're talking about burnout and other kind of life things that can take you away from your profession. So let's start talking a little bit about a typical day for me. So breast imaging is a specialized field of radiology that's dedicated to the diagnosis and management of breast pathologies. Specifically, we use mammography, which is a type of X-ray, and we also use ultrasound and MRI. I'll give you some examples here of a mammogram and an MRI as well. We also perform interventional procedures under imaging guidance. That's something I don't think a lot of people know. And everything's really focused on the breast. So this is a picture of me, with a basically covered up picture of a patient. I am performing an ultrasound guided biopsy. So it's a very real procedure. Everything we do is image guided. That's how it falls under our realm of radiology. So why did I choose this very specific field that many of you may not have heard of? So I feel very fulfilled seeing patients, and my ideal job when I was deciding what I wanted to do was going to be a perfect mix of imaging and direct patient care. I also really love doing procedures, just hands-on procedures. And maybe that's because I played a lot of video games back in the day, I'm not sure, but I certainly wanted one where I had the opportunity to do it every day, if not every other day, okay? And of course, breast imaging is a big part of women's health. We see in male patients, as I'll talk about later as well too. But to me, that was also a really cool aspect of the field. If you're wondering, what exactly we do, where are we? We work in our own clinics, which is different than other radiology fields, but we do spend some time in the dark room, but that's really only about 30% of the day, okay? Our clinics are sometimes called women's imaging centers, by the way. I would say, the majority of the time, 40% of my day is discussing recommendations and management findings with our patients. And that's a little bit different than the other fields as well. And then of course, the remaining part of my day is spent doing image guided procedures, which I've listed them here. They're biopsies, abscess drainages, cyst aspirations, something called a pre-surgical localization where we help the surgeons for a lumpectomy. And I'll go through all of that as well too. In terms of my actual day, this is a very average day that I sort of have. I'm basically doing about maybe like three to four procedures a day. In between, we're doing something called diagnostic studies where we're seeing patients for non-procedural reasons. And then, throughout the day, I'm reading screening mammograms, which are done for patients with no symptoms, and also reading breast MRIs as well too. That's kind of a thing we do throughout the day. Being in academics compared to private practice, let's say, I also teach residents and fellows every day. I give lectures. I'm actually in charge of the resident curriculum. So I help try to think of ways to improve resident education and innovative ways to teach skills. So for instance, here's a picture of me testing out a new synthetic breast model. This was something that I thought would be very useful for my residents to kind of work on hand-eye coordination when they're starting to learn or refresh their methods for doing a biopsy before they actually do it on a real patient. This is a low pressure setting where they can kind of figure out how their subtle movements affect a biopsy. So that's kind of a cool process that, I implemented where I am working now, but I certainly had something similar when I was learning the process. And then on top of that, of course, I'm always doing conference presentations, looking for papers to publish, that sort of thing.
Dr. Chan, this is Gil Salazar. Quick question for you. Along the way, when is it that you kind of chose breast imaging as your subspecialty? Was that something during your medical school years, your residency? At what point did the light go off in your head?
Oh my gosh. I think it was probably during my second year of radiology residency. So I was a PGY 3, I think, at this point. So when I applied to radiology, diagnostic radiology, it was actually the only way to get into interventional radiology at the time. Now you can get into IR kind of through direct pathways. But at the time, IR was considered a fellowship. From diagnostic. And that's actually kind of why I went into radiology. I did a surgical intern year, which I had heard also helps as well. So I was pretty much on an IR sort of mindset until I rotated in breast imaging after my PGY 2 year. During the beginning of my PGY 3 year, I really had a difficult time kind of deciding between the two. And that's when I kind of made my decision. I felt there were a lot more, this was just more suitable for me. I did not know in medical school which specialty of radiology I wanted to go into.
Makes sense. Thank you.
Of course. Just to let you guys know, so the kind of patients that we see in our clinic certainly are mostly women of all ages. We actually see fairly young women as well too, but we see most importantly older women as well. So we've had 95, 98-year-old patients, and I make that distinction because there are some individuals who are very healthy, they're lucky, and they don't have many other medical concerns. So sometimes some of our 95-year-olds are healthier than some of the 60-year-olds that we see. So we do see a wide variety of ages in our group. Interestingly, we also see men, not too often, but probably at least one a day. And that's because men are coming in with lumps and pain as well. Most importantly, there's a small percentage of breast cancer that happens in men, so they can still get breast cancer. It's only about 1%, but it's enough for us to kind of make sure that every lump that's felt on the chest is not a breast cancer. The more common situation is that a lump or a pain, most likely pain, is related to something called gynecomastia, which is benign breast tissue in the male breast. Sometimes those lumps that they feel are something called lipomas, which are benign fat tumors. Either way, these are all things that aren't readily assessed on physical exam alone. So some sort of imaging is needed to help kind of decide which route to go into. Other interesting things too is that men and women can get things like lymphoma. So breast cancer is not the only thing that we actually find, but I'll go into that a little bit as well too. So what do we do exactly in our clinic? So there are three kind of categories that I see of patients that we see. There's diagnostic, there's screening, there's procedures. So I'll first discuss diagnostic and screening. Diagnostic patients are those that have a specific issue, whether it's a symptom they're presenting with, like a pain or lumps, a follow-up of a previously assessed finding that we thought was probably benign, or something that we call a callback from screening, okay? And that's when somebody who has undergone a screening exam, who's asymptomatic, comes back because we saw something that's abnormal. We want to get some additional imaging. What happens during a diagnostic appointment? So the patient's going to get additional mammogram views and or ultrasound views. Kind of depends on the age, depends on the finding as well too. After we get the images that we need, we have to come to some sort of conclusion as to what we want to do with this patient. So that's the management stage. We decide if they are going to return to screening, if we're going to follow up in, let's say, 6 months, if we're going to recommend a biopsy, or in some cases, we may recommend an MRI as well too. Once we've made that decision, we go and we discuss with the patient our recommendations and our management. So a lot of my day really is kind of explaining things in a way that patients can understand, sometimes showing them their images as well too. And then, of course, the other part of this picture is the screening aspect, which is on the other side of the screen. Like I said, these are for asymptomatic patients. Screening in breast cancer is similar to screening in other parts of the body. Our goal is to look for things that are cancerous or at least suspicious before they cause symptoms, right? That's how we decrease resource allocation, how we decrease morbidity, mortality, that sort of thing. So these patients, are getting screened kind of in a different track throughout the day. We don't necessarily see them directly, but if there's something abnormal, we may end up doing so. Otherwise, we're reading their exams and then kind of making analysis to call them back or to say, hey, everything looks good. We'll see you in a year. So at this point, you might be wondering, what are some breast pathologies? So you probably have heard of maybe breast cancer and maybe cyst and not much else. And so this is a very brief overview of all the things that we deal with. And of course, I can't go into every one of them, but I felt that at least I should show you the terminology that we use, some of the different lesions that we see. Some things I think that everybody should know, whatever your stage is that you can't rely on a physical exam to tell if a mass is benign or malignant. I know that obviously when you do a physical exam, you should discuss whether it's mobile, if it's fixed and how it feels, if there's skin changes, all those things are important. But from our perspective, imaging is going to be the true answer as to whether something is suspicious or not. Another fact that you guys should probably know too, IDC or invasive ductal carcinoma is the most common type of breast cancer by far. DCIS, which is ductal carcinoma in situ, is considered a breast cancer as well, in the fact that we treat it like a breast cancer. People need surgery and that sort of thing as well too. And like as I was kind of alluding to before, the only, breast cancer isn't the only thing that happens in the breast. There are cancers from elsewhere that come to the breast. So what we call metastatic disease to the breast. That includes lymphoma, melanoma, lung cancer, and more rarely, the soft tissue sort of sarcomas. Those are a little bit more rare, but I've actually seen a handful of cases, even as an attending for just 2 years or so. So this wouldn't be a talk about breast cancer or breast radiology without just some quick tidbits about screening mammography. So interesting, you may have seen some different guidelines in the news, but I'm here to talk about the ACR or American College of Radiology guidelines because we're radiologists and we're the ones who see the cancer. So we believe that you should be getting annual mammograms. This is for an average risk person, by the way, annual mammograms starting at the age of 40. It's been proven to save lives from breast cancer. It reduces mortality from breast cancer by about 40% in women over 40. And that's because, like I said, we're detecting cancers when they're asymptomatic. So technically early stage sort of cancers. There's actually not really an end age for when you should stop doing screening exams, and that's kind of because there are women who are very fit and they're older and they would benefit basically if we were to find a cancer. So there's no end age to it, and that's kind of an important thing to know as well too. There are some other screening guidelines from the American Cancer Society and the U.S. Preventative Services Task Force. So this is kind of a controversial sort of guideline, but in general, we catch a lot of cancers between the ages of 40 and 50. And if we were to change those guidelines, then we would obviously miss those. Okay, so from the radiology perspective, age 40 and over, annual mammograms is what we recommend. Now, high-risk women is a different story, okay? So high risk means that you have a lifetime calculated risk based on, there's different models out there. You kind of input all your information. You have an elevated risk of 20% or higher, okay? Or you have a history of things like chest radiation for a different type of cancer when you were a kid. So all of those things kind of get put together. And if you're in this category, you actually are recommended to get yearly mammograms earlier than that, okay? Mammograms and breast MRI. Usually they're both going to be yearly, but they can alternate. So it's kind of like this. That's how I would put it. So you have a mammogram every year, you have an MRI every year, but you kind of stagger it so you have something to do like every 6 months. Most importantly, all women, especially certain groups, should have their risk evaluated by age 30. Okay. So what exactly happens after a screening mammogram? This is a great diagram from one of our big sites here. So if 100 women were to get a screening mammogram, 90 will be told that their mammograms are normal, which is great. 10 will be asked to return for additional mammograms or ultrasounds. And out of those 10, we kind of break it down even further. So 6 will actually be totally fine. And that's because a lot of the things that we see on screening mammogram can actually just be normal tissue that's overlapping. All right. And I'll kind of show you obviously some mammograms later so you have an idea of what I'm talking about. But essentially, additional imaging is showing that things are okay. There's nothing suspicious in these areas. 2 out of these 10 will be asked to return in 6 months for a follow-up exam, meaning we think that things are probably going to be okay. The chances are very low that we need to biopsy this. We'll just see you again in 6 months. Okay. And out of the 2, then there's 2 out of 10, they'll be recommended to have a biopsy. All right. So that's kind of a nice breakdown of what happens after a screening mammography. I'll talk a little bit about the actual imaging modalities that we do now, so you can have an idea of the pictures that I sort of see. So X-rays, are the oldest and most commonly used form of medical imaging. I think of it as allowing us to see inside the body at a very, very tiny cost of radiation. Each screening mammogram has 2 views of the breast called the CC or the craniocaudal and the MLO or the medial lateral oblique. And I included some diagrams here to kind of show you what they would look like on the patient and the kind of picture that you will ultimately see. This picture is of a mammogram machine in case you haven't seen one. Ignore this, the small one in the back, that's like a different machine. But the one in the front basically is the black kind of square is a detector. The breast is going to go right on there and the paddle is going to descend and kind of compress everything. So compression is necessary, not because we want to torture patients, but because it actually creates a clearer picture. We want to reduce the amount of tissue that an X-ray has to go through to make the pictures clear. And we also want to make sure there's not any motion. All right. So by holding things still, we are getting the most accurate picture of subtle findings that we're going to be seeing in the breast. And at the end of the day, radiology is basically a study of abnormal versus normal. Right? We're looking for things that are normal. We're kind of checking it off in our head and we're kind of looking and pinpointing things that are more abnormal. And this is the best way to kind of make that difference the greatest for us. Here's an example of kind of how we can look at a CC mammogram. So the best way I think of this when I was first learning this, the picture on the screen left is going to be the right breast. The one on the screen right is going to be the left breast. And I just kind of marked it for you because it does vary. I think there are some different hospitals that do it differently. This is the general idea though. To best visualize how we even got this picture, just kind of imagine yourself as this person here and you're looking down at your feet. The top of the picture is going to be your lateral part of your body. So it's going to be where your arms are, okay? The top of each of these pictures. The bottom part of the picture is going to be the medial part of your breast, which is actually going to be your sternum. So things that are down in the middle. In terms of anatomy and what we're looking at, so I labeled kind of what I just said here. Lateral is going to be where your arms are. Medial is going to be where your sternum is. There's a vague sort of white band kind of in the middle of the picture and way back that's going to be labeled with the purple. That's actually going to be your pectoralis major muscle. We sometimes see only part of it. This is not the best view for it, but since it's here, I might as well point it out for you. And then the most important thing that I want you guys to take away from mammograms in general is that fibroglandular tissue is going to appear white. Okay, that fibroglandular tissue is normal breast tissue. That's in comparison to what's black or gray, the rest of the breast, and that's all going to be fat. So I think of the breast as tissue and fat. Now, the interesting thing is that when cancer is present, cancer is going to be white because it comes from tissue, right? It doesn't come from fat. So essentially, I'm looking for something abnormally white, and hopefully it's not normal white. It's not the normal fibroglandular tissue that's there. There are masses, of course, that are containing fat, like those lipomas I was talking about earlier. And those masses are not going to be white at all. They're going to blend in with the black part of the background. And I'll talk a little bit more about this when we discuss density, because it's actually pretty important. Before we do that, let's take a look at the MLO view. This is the other view we get for a screening mammogram. This view, as you can tell, has a lot more breast tissue than the CC view, okay? The superior part of the picture, this is kind of a little bit easier to understand, I think. The top of the picture is going to be where like your clavicles, your neck, and your head is going to be. And then, of course, underneath is going to be where your upper abdomen is. And I've labeled everything here. Some things I want to point out, this white band on both sides, far back in the breast, that's your pectoralis major muscle, okay? We actually also see kind of like these little masses in the back, and those are your axillary or armpit lymph nodes. Those are very important because breast cancer, if present, and if it was to metastasize anywhere, often goes to the lymph nodes in the axilla. So we actually sometimes can pick up breast cancers when we see an abnormal looking lymph node in the armpit area, which is within our field of view of mammograms, which I don't think a lot of people know. Most relevant too nowadays is that with COVID vaccines, these lymph nodes tend to get a little bit big and reactive. This is something that's actually not unique to the COVID vaccine. Okay, we see it with like the flu vaccine. We see it with skin infections of the arm, like anything that kind of like irritates but is not cancerous can make your lymph nodes a little bit large. It's an issue for us right now because a lot of the times we are seeing these big nodes on screening mammogram, and then we have to kind of find out if we have to be worried about a breast cancer or if it's because somebody just had their COVID vaccine. Now, when these lymph nodes get big, by the way, it's temporary, okay? It comes up a few days after you get your vaccine and it eventually goes away. So, and it shrinks back to normal is what I mean. So what we tend to do is we get an ultrasound of the area. Ultrasound's the best way to look at lymph nodes. And we just kind of do a follow-up. We do about, it can vary between 4 to 12 weeks. We do, between 4 and 8 weeks or so. And as long as everything goes back down to normal, then we can be rest assured that this is not a breast cancer. Of course, another thing I should point out too, if you were to get the vaccine in your right arm, I would expect your right axillary lymph nodes to get big. I would not expect your left side. So it's something called ipsilateral lymphadenopathy that we see in this, particular climate. Let's talk a little bit about breast tissue density. So I don't know if you've heard this term before of breast tissue density. Clinically speaking, there's not really a good way of telling if your patient has dense breasts, okay? And that's because it's just not reliable between physical exam and what we actually see in mammography. And density is something that us radiologists have classified, okay? There's 4 different classifications of it, and it's all based on mammogram. 80% of the general population is going to fall somewhere in the middle, okay, between what we call scattered areas versus heterogeneously dense. You don't necessarily need to know these terms. You just need to know that there's different types of density. And then, of course, 20% is going to make up kind of the extremes, very fatty or very dense. Density is simply the ratio between tissue and fat. When someone is very dense in their breast, it means that they have a lot of tissue and not that much fat. If they are not dense, that means they have more fat, less tissue. Very simple. So this is something, like I said, that's kind of determined by mammogram. In general, I think density is related to genetics. It's not related to volume of the breast or anything like that. There are some things throughout your lifetime that can certainly affect your density. When you are younger, you tend to have more tissue compared to fat. So when you get older, you're basically going to go kind of like backwards from this picture, okay? You're going to get decreased density with older age. If you are breastfeeding or if you are on hormone replacement, those are all things that can increase your density as well too. They increase the amount of tissue in your breast while kind of keeping fat the same. Interestingly, if you gain weight and you happen to gain it in your breast, you are decreasing your density, right? Because you are adding more fat and keeping the tissue the same. So there are some kind of lifetime things that can affect your density. Now, why do we care about density in the first place? So like I said before, cancer comes from tissue, not fat. So cancer, when it's there, is also white on mammogram. Let me give you some examples here. So in this first rectangular panel here, let's say that I'm looking for something abnormally white, like this little white bunny on my mammogram. In this patient that's, not very dense, I see more black tissue compared to white. It's probably going to stand out fairly well. In the next patient, which is a different patient, am I going to be able to find something abnormally white as easily? No, because it's kind of like looking for like a snowball and like a snowfield, right? The contrast is just not as easy for me to tell. So when someone is denser, they're more white on their mammogram, and therefore it's harder to see cancer. So density does affect our detection and also like someone's actual risk of developing breast cancer as well too. Let's talk a little bit about ultrasound. So this is another one of those old school imaging modalities. The best part about ultrasound is that it has no radiation, okay? It's very good for soft tissue in general. Ultrasound certainly is not just for the breast. You may have heard ultrasound more so for, let's say, the gallbladder or other things in your abdomen, or even like your foot if you had like a splinter or something like that. So it's very good for soft tissue in general all over the body. The only disadvantages is that there are some things that can limit evaluation. Air and calcifications, which is literally deposits of calcium, can affect how accurate ultrasound is. And then of course it's very operator dependent, which just means that you have to trust your technologist or trust yourself when you do an ultrasound. Now, this
Chan,
is, yes.
forgive me for one second while you're mentioning kind of density and different modalities. The chat is blowing up, and one of their questions is how do breast implants kind of affect your reading? Forgive us if we're jumping ahead, but the students are very curious about that specific aspect.
Yes, yes. So I have a whole section on implants. Implants does not necessarily affect density because it's just kind of adding like a fake breast inside, something that's artificial. But I'll tell you that, we still do mammograms on people with implants. Doing procedures, like let's say a biopsy, can be a little trickier because we obviously want to put a needle in a mass, a suspicious mass, and not in the implant itself. But people with implants basically still need to get screening mammograms. Sometimes there are some lesions that are a little bit harder to see, but we actually have come up with a lot of great ways to kind of reposition the breast so that we can see it well, the real breast, that we can see it on mammogram. And I'll have some pictures to show you as well too. But it's always, I know it's an interesting topic, so I certainly included it. Talking about ultrasound briefly too. So this is the first imaging test for women under 30 that are presenting with a breast lump or breast pain. The reason why we recommend this for younger women is because mammography has radiation, and it's also less useful in dense tissue as well too. So what I'm saying here is actually an official recommendation. So if you haven't heard of this yet, it's pretty useful. It's called the ACR, American College of Radiology, Appropriateness Criteria. This is not just for breast. This is for many other things. It's essentially a really good tool for clinicians, for non-radiologists, when let's say they have a patient with chest pain and they obviously know the age, they know the gender, but they're like, okay, what is the first study that I should order? What's the most recommended imaging study that's not too costly, that's going to give me an answer, that's going to make a difference? So this group, the Appropriateness Criteria group, basically take all these clinical scenarios and tell us what radiologic study is most recommended. The easiest way to understand this is in the middle column here where it says rating. So the rating scale is from 1 to 9, and 7, 8, 9 is going to be the most appropriate. Okay. Scale 1, 2, 3 at the bottom is going to be not as appropriate. So as you can see here, for this particular clinical situation, a palpable breast mass, a female younger than 30, a breast ultrasound gets a rating of a 9. So that's like the first thing that you go for, which is kind of important, I think, because ultrasound is very good at looking at soft tissues. When we talk about breast ultrasound, by the way, just so you have an idea of like what's happening during it, the patient's going to be supine. And I think of supine as, when they're sitting like this, like holding a cup of soup, supine. So they're on their back. And the probe is going to be placed at the top of where the picture is. That's going to be the front of the patient. At the bottom of the picture is going to be pictures of the chest wall, okay? And during biopsies, that's the area that we stay away from because the chest wall, obviously, is going to be full of muscle and, more importantly, lungs. And we don't want any needles to go anywhere near that. So that's the whole point of image-guided procedures, by the way, is that we're not just blindly putting things in, okay? We're also not making big incisions and opening things up like a surgeon does. We're using imaging to minimally perform these procedures under guidance so that we're not hitting arteries or muscle or lungs or anything that we don't want to damage. The last imaging modality I'm going to briefly go over is breast MRI. So just so you guys know how patients position for this, it's actually the opposite. So a patient is going to be positioned prone with their breast hanging through a window. It's kind of weird, but the whole point is to help extend the breast tissue. That's in contrast to a CT, if you've ever gotten one. Most CTs are going to be done with you lying on your back. And that's because in the CTs, breast tissue is going to be compressed, if you think about it, and it's going to be harder to evaluate. Now, who needs a breast MRI? This is a very specific sort of study. And for all of you who are asking about implants, this is going to be your first picture of what implants look like, okay? Patients who have silicone implants and are worried that it's ruptured, MRI is going to be your gold standard, okay? High-risk patients as well, those with greater than 20% lifetime risk. and some other patients as well. So the ones that have biopsy-proven cancer, let's say that you get a biopsy of your right side, you know it's cancer. Before the surgeon brings you in for any kind of operation, they might want to know if there's other cancer elsewhere in the breast that's very small, hard to see on mammogram or ultrasound, but MRI is going to be able to pick up those small abnormal areas. And of course, there's a subset of people that have already had breast cancer, they've had surgery, but someone's concerned that the disease has come back. MRI is going to be the most sensitive for those people as well, too. I guess we can go to any questions before I go into cases, which would be the second half of the talk.
So we've got a decent number of questions for you.
Okay.
First off, are there any PAs in radiology?
There are not. We have, so basically radiology is a unique sort of field because we don't really have like nurses as well too. We have technologists. So it's basically going to be either a physician, MD or DO, and then a RT. I think that's for radiation technologists, where they're the ones who are taking the images. Unfortunately, the interpretation of images is really, really tough. I mean, you need to have like medical school residency, like so much. So we do not have any PAs currently. In not just at my institution, but like anywhere, there's no radiology PAs.
There are some, like our institution, for example, they use APPs and PAs for some of the kind of the follow-up and clinic aspects of it, kind of procedurally. There are not very many, but they're employed in kind of that subset of the health system.
Yes, we had good point. We have an NP that helps reach out to patients about any questions. They help us convey or communicate radiologic pathologic correlation as well too. So we do have mid-levels that are helping us.
Thank you for letting us know. Another question is, so is being more dense going to lead to a higher chance of developing breast cancer?
Yes, it's that, and then also that it's harder to detect as well. But inherently, yes, if you have more tissue, you have a higher risk of developing breast cancer.
All right, thank you for letting us know. Another question is, how has technology changed in radiology through your time in school and during practice?
Well, it hasn't changed like that much since I would like to think I'm pretty young. I see it mostly with the attendings that I've trained under. So some of the ones that have been at the forefront of radiology are really, really, really good at ultrasound and X-ray, like crazily so. They have, like hawk eyes for a lot of these very subtle findings. The problem, I think with, like kind of like my generation is that we were trained with cross-sectional imaging from the start, CTs, MRIs. So, we're able to kind of get away with learning more about a clinical scenario from cross-sectional imaging. I would say that we're not as good at subtle things like X-rays compared to the ones that exclusively studied that. That being said, a lot of these faculty members may not have as much experience with MRI because that's technically a little bit newer. So I see it in the people that I've trained under. As for myself, I haven't seen too much that's different. I think there's there's one procedure that is a little bit different now, but in terms of imaging, I haven't seen too much, but that's only because, I've been doing this for like 7-ish years or something like that. So.
All right. And then here's a follow-up to that. How do you think radiology will look in the future? How would technologies like machine learning play into a radiologist's daily life?
Oh, yes. So AI, this is always a good question. There's a lot of different programs that are out there that are either in development or in the training stages and that sort of thing. We use some form of AI. It's computer assisted detection, really. And it's basically the computer kind of pointing out abnormal things on mammograms to kind of like help us decide. Let's say when we're reading a screening mammogram, it may put like a little X or something over an area that it wants us to look at, okay? The only problem from an anecdotal standpoint is that it doesn't detect a lot of subtle findings. And on the other hand, it also can kind of draw your attention to things that are definitely okay. So we kind of use it as an adjunct. I think in the future, once the technology is really there, it might be useful in my field, let's say, for patients with really fatty breasts, so ones that are not too dense, like the more straightforward cases. Okay, I think that AI can probably make our lives a little bit easier for those like so-called normal cases. I still think for the more difficult cases, I mean, you're going to need like a radiologist's eye for that. So I do see some role of AI. When I was a fellow, I was involved in a project for lung nodule screening, where they were testing out a program and trying to see if they would have us read basically a CT chest and ask us to find lung nodules and to measure them. And they would compare it to this AI sort of version where they picked it up as well too. The interesting thing I remember is that the AI program picked up a lot of false positives. So it would tell you to look at this one area and it's actually like not a nodule. So I think that there is definitely potential. The most reliable thing I think would probably be for the more normal, like straightforward sort of cases.
All right, thank you for letting us know. Another question, this is a lot of people have asked, how do you talk about a positive finding with a patient?
Oh, it's definitely a skill. It's a skill that, was important enough that when I was in residency, one of my attendings actually made a point that we had training in this. So at the end of the day, the people who go into breast imaging tend to care about communication. It's not like the others don't. It's just that we really value it. We want to spend time perfecting it as much as we can. And that's what it comes down to. The first, I think, important thing is setting the expectation when you're talking to somebody about a biopsy in the first place, okay? We do kind of rate our level of suspicion when we first talk to a patient about a biopsy. If it's something that I have a low suspicion for, but technically still want to do a biopsy, I try to relay that as much as possible. If it's something that's more concerning, I'd rather be straightforward and let them know. And at the end of the day, imaging is not the end all be all. It's pathology. My goal is to get them to the biopsy. But I feel like if you tell them this, you kind of convey that seriousness of your suspicion. If they were to get a malignant result, I think it's a better reaction. And I know that as a patient, that's what I would want too. I would want a physician to be straightforward with me from the start. The conversations are definitely tough. Some people take it much more easily than others. It's very interesting. But certainly there are ones who are very worried for what we call, let's say, the high-risk lesions. So on that chart that I had showed before, not everything is just benign or malignant. Unfortunately, there's a section within this group that's called high-risk lesions. And those can be really tricky because these are technically lesions that are benign, but in past studies where they've taken out more tissue, they've gone to surgery, more tissues come out, you give it to the pathologist actually upgrades it to a cancer like 15 to 20% of the time. So what we've learned from those studies is that every time we diagnose a high-risk lesion, a patient has to go see a surgeon, kind of discuss the risk benefits. I think those are difficult conversations to have because you're telling a patient, hey, this is, not technically a cancer, but we still may recommend a surgery. So those can be difficult. At the end of the day, it's really all about communication, I think, and being empathetic and understanding what it would be like if you were to get the news. And then I think people appreciate what you're doing for them.
That's definitely good to know. All right, let's just say one last question before we move on to the rest of the presentation. Often things on images are really subtle and hard to decipher, as you've said. So in these cases, how do you explain and point out these findings to patients and or family members when they want to see the image results for themselves?
Yeah, it's really tough. I try to kind of decipher as best as I can. And that's kind of part of what I'm going to be doing in the second half of this presentation, quite honestly, because I'm going to show you some more of the obvious findings, but I'm going to try to describe it in a way that you may understand. Of course, I hone in specifically on a specific area. I compare to the other breast. I tell them the level of suspicion based on what we're looking at. I think people have a lot of difficulty with ultrasound. Okay, that's a very tough one for both clinicians and non-doctors to understand. I mean, I think before I started radiology, or even when I was a first-year radiology resident, ultrasound just looks like a big blur of like nothing. So I definitely take my time to go over things with people and tell them what I would expect to see in a completely normal person. And in your case, like it looks like this, which is why I'm a little bit more suspicious. So I try to explain it as much as I can in layman's terms. And that's really a big part of our job, because we can't just use radiology terms with everyone. So
Dr. Chen, and one of the speaking of ultrasound and kind of patients having difficulty with that is, in emergency medicine, we've gotten pretty good and pretty savvy, handy with ultrasound, but it is also the source of one of the most common times when patients ask for a second opinion. And so I don't know if you have any thoughts on that. A student had a question specifically about that when they have doubts, they want a second opinion, how you handle that.
Yes, we get that all the time. We get that even between radiologists, right? So somebody will have a read and they want to have a second opinion. I think that's totally reasonable. There are some patients who, I don't even blame them. It's just they just want to get another set of eyes on something. I'm very lucky that I'm part of an institution where we do second kind of looks all the time, in the sense that I feel comfortable asking colleagues for a second look. All right. And I do it for my colleagues as well, too, because we all understand that even just catching a different perspective can be useful. So, I don't mind doing it. I don't blame anybody for asking. We're all in it together. And as a team, our job is just to make sure that things are the right thing for the patient. So.
We can move on to the next part of the presentation then, I guess, if you'd like.
Okay. So let me just go over some cases with you here. So this is an example of a mass. This is a 56-year-old female, and she's feeling a right breast lump that's marked by the BB. So I don't know if you guys have seen BBs on x-rays or mammograms before. It's this really bright white dot, okay? So I just circled it for you because if I didn't, you may not see it. What happens basically is the patient comes, our technologist is gonna chat with them and be like, why are you here? Patient's gonna be like, okay, well, I feel something right here. And she's gonna point to it. And if she doesn't, we ask her to point. And then the technologist is gonna put a little sticker that has a little metal dot on it and place it right over the area. So that when she takes the pictures and we are trying to evaluate where the patient's feeling, we can kind of correlate it the best. This is kind of a classic scenario. So we're asking, where exactly in this right breast is the problem? And this actually should say right, I don't know why it says left. It's going to be the right breast problem. And this is actually going to be the mass, as pointed out here. Now, one thing I want to kind of show you is that, look, it's the exact same sort of whiteness as the rest of the breast, right? But it looks different. It's kind of like by itself. It's an island of tissue. It looks like it's kind of forming a ball. So when you see this mammogram, you should think a little bit twice about, if you're finding a reason for this patient's lump. After we do a mammogram, what we do is an ultrasound, okay? An ultrasound is going to show you this irregular vascular mass. And in the second picture on the bottom, basically these red marks is basically the system creating a color where things are moving. All right. And when things are moving, that's going to be blood vessels. And that's how we determine vascularity for a mass. Now, this is important for us because a lot of the times cancers that are vascular, that's what raises the red flag in the first place. A mass that's able to recruit blood vessels to itself, called neovascularity, that's what's going to allow a tumor to grow faster than the rest of the body. That's how anybody creates cancers in the first place. That's how one part is getting bigger while the rest of your tissue is just like hanging out and being normal. So in the setting of a lump, when we see something that's irregular and vascular on ultrasound, we're going to want to biopsy this because this looks very suspicious. And we were going to biopsy under ultrasound guidance, kind of like that picture of myself that I showed you initially. The pathology came back as a cancer, an invasive ductal carcinoma, which is our most common type of cancer, of course. I just want to touch briefly on what masses are. So it's kind of funny, but masses are technically 3D space occupying structures, all right? And, we look at the shape and we look at the margins to determine how suspicious we are. We are generally taught that if something looks like this, what we call spiculated mass, where it kind of looks like something is exploding, we need to be a little bit more suspicious of something like that compared to one that's more circumscribed in general, all right? And I point this out because masses, that word is a very scary, scary word. When we use it with anybody, it's very scary. Nobody wants to have a mass anywhere. It's very abnormal. But technically, a cyst, which is benign, or fibroadenoma, which is the most common type of benign breast cancer or breast tumor, breast mass, these are all technically masses and they aren't bad. They are not cancers. So that's something I always want to distinguish as well. Like it is occupying space, but it's not necessarily bad. At the same time, just so you guys know, we aren't really recommending that people do self-breast exams anymore. I know that was a thing at some point. What we really recommend is that patients just know how they feel at baseline. So when there are additional lumps or any changes that they are able to they know that something is happening and they'll come to us for evaluation. The problem with routine self-breast exams is that it really increased, patient anxiety, a lot of false positives and that sort of thing. That being said, I think knowing kind of your routine, regular background is really important. And you just come when things feel a little bit different.
You feel, Dr. Chan, then that the best approach is, folks in the chat wanted to know what are the things we should be looking on self-breast exams. And to some degree, definitely if you feel any masses, lumps, especially out of the ordinary, go to a healthcare provider for assessment. So doing away with self-breast exams should theoretically lead to kind of routine screening for women. Is that the wave of the future?
I think so. And I think, a lot of breast surgeons agree with this as well, too. It's really just knowing how you feel at baseline and any changes. Now, lumps is certainly, the biggest thing. There actually are other findings everyone should also look out for. Okay, so there's skin changes. So if your skin feels like it's getting thicker or redder, anything like that, that's also important. And any nipple changes as well too. So nipple discharge is actually a whole category of things that we also look at. Some people may not think about it, but for instance, nipple discharge that is bloody or bloody and spontaneous, meaning it just kind of comes out on its own, you don't have to press on it. And this usually presents, by the way, not with people just like bleeding out when they're walking around. It's when they look at their bra and they see some brown or red discharge on their clothing. So that is another thing to look out for, in addition to lumps and that sort of thing. And of course, lumps in the axilla are also important as well too. So there's a few clinical things that you can always look out for. But I just feel like, if you're worrying about every single lump and bump, then you're going to be coming in quite often. That's all. And this other, let me go down to my second case here. So this is an example of what we call like an OK mass. So this is an 81-year-old female who is on anticoagulation, and she's here with a breast lump. So as far as I remember, she was on anticoagulation because she had a stroke at some point within the last year. She needs to be on medications that kind of lower her chances of creating clots, okay, because we don't want another stroke to happen. The kind of side effect that sometimes can have is that you can create things called hematomas, and this is what this is. So she came in with a breast lump. Obviously, the first thing we worry about is going to be a cancer. And we see on the mammogram that she certainly does have a cancer on her left side. When we do the ultrasound, there's a little bit more black than gray. This is one of those subtle things as well, too. But this makes me think that there's a little bit more fluid in this mass than if it was a true solid cancer, okay? So then what ends up happening is that we numb the area with some local numbing medication. We put in a needle and we aspirate it. And the thing actually completely collapsed on real-time imaging. That red stuff, that's blood, that is a hematoma. So obviously we're asking this patient, like, do you remember falling or running into the door? Anything that I assume you would have told me before. And she didn't remember any particular traumatic event. So basically, there are certain populations, those that are on anticoagulants, for instance, that tend to bleed a little bit more. It can actually look like a mass on mammogram, but ultrasound and, of course, the diagnostic evaluation would be aspiration, where you actually can see the contents of a hematoma. Okay, so that's also a pretty cool case. My third case is a 29-year-old who's coming in with a left breast lump. So she's 29, and we're asking, what imaging study should she get first? It's going to be ultrasound because of her age, under 30, like we said before. And this is her targeted ultrasound right over that lump that she had felt. So the first thing that I see is like this oval circle, like what is all this stuff here? This is exactly what she's pointing to. It turns out actually, and I kind of draw the anatomy here, that this is her rib. This is the pink thing, okay? So patients that are very thin, that don't have much breast tissue, can sometimes feel like they have a lump, and it actually turns out to be a rib. If I extended this picture out to the left, I would see another oval circle. If I extend it to the right, I would see another oval circle. And that's how I know they're ribs. The interesting thing is that we're seeing them kind of like end on. If you're to turn the probe the other way, you would see a rib in its long axis. The way we're seeing it now is kind of like end on like this. So you're only seeing part of it as if you were like chopping the ribs, right? But you're not, you're just getting like that kind of view. Other parts in this picture I want to point out. At the top is going to be the skin. If you have had radiation for cancer, let's say, or if you have a skin infection, this area is going to be a little bit thicker than normal. So we can tell that on ultrasound. This area that's marked in blue, that's the breast tissue. That's where we're looking for masses, cysts, etc. It's a mix of gray and white because, like we said before, it's a mix of tissue and fat. This long kind of drapey thing that's, kind of going over the rib, that's your pectoralis muscle. And that's kind of protecting everything that's underneath, which is your ribs and your lungs. And it's actually very cool because ultrasound's dynamic. So when I am doing an ultrasound and the patient's obviously breathing, I can see everything kind of move up and down. I can see the lungs moving as well too. And when we do our biopsies, obviously we are staying clear of that general area. Let me talk to you a little bit about calcifications because this sometimes does come up. So these are basically calcium deposits in the breast, and they're actually fairly common. They can be in different parts of the body as well. The interesting part, though, in the breast is that they can be associated with cancers. Okay, they look like bright white spots on the mammogram. I'll show you in just a second. The most important thing is that they can be good or bad. It's our job to look at their shape or their morphology and their distribution within the breast. There's some that we look at that are 100% benign, we don't even follow. And then there's others that are very suspicious for cancer and need to be biopsied. And there's ones that are in between. Most importantly, calcifications cannot be felt. So these don't cause pain, they don't cause lumps. So all the things we were discussing about, like look out for this on your physical exam, you're not going to find these abnormal findings of calcifications. That's something we only see on mammogram. And I say that's important because, we have a lot of patients who don't want to get mammograms. They say, hey, I just want to get ultrasound. I can lie here. I don't want to be compressed. That should be good enough, right? Like you should be able to catch a mass on ultrasound. And I mean, that's partially true, but we won't be able to catch calcifications, which are very commonly associated, certain types are commonly associated with some types of breast cancer. So let me show you some examples. So this is a 65-year-old who's presenting for a screening mammogram. Something that's a little bit different on this mammogram, right, compared to the ones we've seen before. There's all these like crazy bright white lines that are going everywhere. So these bright white lines are actually vascular calcifications. They are curvilinear. They're tram track, meaning they're kind of lining like a tube like this. So you can kind of guesstimate where these vessels are. This is a completely benign finding, meaning that these are not cancers, these are vascular, totally normal in someone who's a little bit older, okay? Now, the interesting part is that if this patient was actually on the younger side, let's say she was 41, and she had this many vascular calcifications, I might have to wonder if she has another systemic issue going on. Is she a diabetic? Does she have renal issues? Because it's unusual for a younger person to have so many vascular calcifications in their breast, okay? It's still technically benign, but it is something that, we would have to think about at least. Now, that's in contrast to this type of calcification. Now, I don't expect you guys to necessarily know like the shape or anything, but hopefully you can tell that these are not tram track. These are not going in a tube like this, all right? These are actually very, very suspicious. These were caught on a screening mammogram, meaning the patient had no symptoms. And based on their shape, we're giving them about a 51 to 95% chance of malignancy. When we see this, we have to have the patient come back. We do some extra images. Ultimately, this person got a biopsy and it came back as DCIS. So my general point is that calcifications having them is not abnormal. It just depends on the shape and the distribution. And once we see a suspicious distribution, we're going to want additional pictures and we may want to biopsy as well. And we do not biopsy all calcifications, most importantly. Okay. Let's talk about breast implants. I know you guys are asking some questions about this. So we've encountered this many times where someone says, I have implants, should I still get mammograms? So our techs actually have special methods to displace implants during mammography. As you can tell here, the full view is just kind of like a regular, not really displacing any tissue. As you can tell, all this breast tissue is getting really squashed, okay, by the implant. But then there's another view where the technologist is going to try their best to kind of push the implant out, so all we see is the breast tissue, the native breast tissue. And that's what we care about, right? Because cancer is not going to happen in the implant, which is artificial. It's going to happen in the remaining breast tissue. So my point is that mammography is still very useful in these patients. It's not like they're more prone to developing breast cancer. Sometimes they're, depending on the location, it may be tougher to see cancers, but in general, we do pretty well in seeing cancers in people with implants. So if you have implants or you know somebody who does and they don't want to get a screening mammogram, that's not true. There's still a lot of utility for that group. Now, is there a chance of rupture? You know, I have never seen it. I think in the literature, there are some cases of it. I would imagine that if your implant ruptures during a mammogram, they probably were not new implants. They probably were around for quite a while and maybe had a micro sort of rupture to begin with, or kind of going down that path anyways. In general, I don't know if you've seen, plastic surgery videos where they kind of show you how pliable a breast implant is. They're like throwing it everywhere. They're like stepping on it. So it's a pretty tough sort of construction. Mammograms don't rupture implants. I know that prevents a lot of people from wanting to get them. This, by the way, is what an implant actually looks like if you've never seen one. This is definitely on the larger side. This is 760 cc's. This is essentially what we're seeing on the mammogram. So it's pretty cool. Of course, the concern with implants as well is that it has ruptured. So there are generally two different types of breast implants. There's silicone and there's saline. Saline's like the more original one. That was like the first one, but people are still getting them. This mammogram is showing ruptured saline implants. So as you can tell, they kind of look like origami, right? They're like kind of crumpled down. The interesting thing is that if you have saline implants, you actually don't need any imaging to tell you if it's ruptured or not, because you can tell on a physical exam. One side is going to be flatter, or in this case, both sides are going to be flatter than usual. The patient is going to be able to tell you that their implant has ruptured. And when it happens, it's not a tragedy. The saline is going to get resorbed by the body. The only issue is that, maybe they're going to want to see their plastic surgeon and get it redone. And maybe they won't. This person actually, she knew about her implant ruptures. She obviously didn't really care about it. And she routinely got her screening mammogram like a good patient. On the other hand, there are silicone implants. And when those rupture, they actually may not change that much on physical exam. So there probably are a lot of people walking around with silicone implants with tiny ruptures and they don't know it. And that's because silicone is more viscous. It's a gooier sort of liquid, for a better lack of a term. And so if it was to rupture, it doesn't cause as dramatic of a difference. And it doesn't move like that far away into the body. It's not going to like spill out and all that sort of thing, just like saline does. Now, silicone can get out into the breast tissue and it actually can get absorbed by axillary lymph nodes that are just doing their job. So sometimes we do see silicone in the lymph nodes. It's not necessarily a bad thing, but it is a sign of an implant rupture. The gold standard, by the way, for silicone implant rupture is going to be an MRI, and that's going to show you the different types of rupture that a silicone implant can have. Silicone implants on mammogram are very bright. They can be a little bit tough to tell if they're ruptured. Same thing with ultrasound. So MRI is really the mainstay. So last part of my talk, I'm just going to talk to you guys about the image-guided procedures that we do. Just so you know, we use local lidocaine for all our procedures. There's no general anesthesia or sedation. So someone can eat whatever they want in the morning. They can drive themselves. They're going to be totally fine to drive themselves home on the way back. If they want to ride, that's great, but they technically can drive themselves. So just so you guys know. So our most common procedure is going to be a biopsy. That's tissue sampling. The specimens are sent to the pathologist, the specimens that we take out, and you get the results in a few days. So you don't know the day of the biopsy what the results are. The other doctor, the pathologist, has to look at it under a microscope and tell us what it is. We do something called a pre-surgery localization. That's basically pinpointing a cancer, a biopsy-proven cancer, for a surgeon. And this is for the procedures called lumpectomies, where they try to take out the least amount of tissue, but the correct amount of tissue without leaving anything bad behind. We also do abscess drainages and cyst aspirations as well. This is a very common procedural tray that we have here. Sterile towels. There's an ultrasound probe cover that's underneath here, a scalpel, and our biopsy device as well too. So let's go into one of our first procedural cases. So this is a young lady with a left nipple ring. She came into us because she had a subareolar, meaning underneath the nipple, red lump, and it was just not responding to antibiotics. She had seen her PCP, who gave her antibiotics thinking that it was an infection, which wasn't wrong, gave antibiotics, but it just wasn't getting better. So the first thing we do is we do an ultrasound. That's going to be the best for soft tissue, especially for the acute setting. And we see that there is this kind of mixed density sort of thing in the left breast. This looks very big on pictures, but you can tell at the very bottom here, we always have measurements. It's about 4 centimeters, okay? Which is kind of big in the breast, if you think about it. So this is an infected pocket of fluid. This is an abscess. This patient is coming in with focal breast erythema or redness. There is pain and it hurts. It's very vascular around this area as well too. At this point, no amount of antibiotics is going to help this thing go away. When it's small, certainly it can help and the body can kind of figure it out. But at this point, she actually needs someone to go in and take that fluid out. So what we do is an abscess drainage, which is similar to a cyst aspiration, very similar kind of studies. So what I'm showing you here is under ultrasound guidance, we're putting in this needle that's a bright white line, and that's going into the abscess, okay? This is after we've given numbing medication, of course. So what comes out? All this stuff comes out. So this is purulent fluid with a little bit of mix of blood, as you can tell here. And this, we again can see the abscess completely just flattened. This is all the infective fluid that's in here. What we need to do is send that for pathology so that we can kind of narrow down what organisms are living in here. Once we're able to do that, and the pathologist is really going to help us with that, then her PCP can give her antibiotics that are more specific and better at killing the bacteria that's in there. This is an infection. If we didn't exist and nobody was able to take out this fluid, for instance, she could definitely get really, really sick. Her white cell is going to go up, white cell count is going to go up. She's going to have fevers. This can become a systemic issue because it's truly infected. And I give you the point about the nipple ring too, because I mean, it has to be related to that. Having a ring, it's basically like a skin puncture, right? So it increases, it's a nidus for infection. Now you can still get abscesses without having nipple rings or tattoos or anything like that. But certainly if you get one of these things, there's always a risk of an infection that's happening because you're puncturing the skin, which is, the body's first defense system against any sort of infection. The last thing I'll talk to you guys about is the pre-surgery needle localization. So just some terminology, a lumpectomy is, like I said, when a surgeon removes only the cancer, but they need guidance on where that exact spot is. That's in contrast to a mastectomy where they're taking out the entire breast, and they don't really necessarily need us for that. So what happens is basically this patient had a biopsy-proven cancer. This little rectangle you see here is a little clip that we place after all of our biopsies. So it's easier for us to kind of revisit that area if we need to, which in this case we needed to. What we do is we place a needle and a wire down to that area under mammogram. You can do it under ultrasound or MRI as well too. And what happens is that we're placing it right to the area that needs to be taken out. And as you can tell here, this wire is going to be the same thing as that wire. The patient comes to us the morning of her surgery for this procedure. We place the wire down to the cancer. The patient is wheeled off into the operating room that same day, and the surgeon uses the wire to take out the cancer. So the whole premise of this is that it's very difficult to find this small area just by looking at it in the operating room. So we localize the cancer for the surgeon. Now, to make sure that everything was taken out that was supposed to, when the surgeon takes out the tissue, they're actually going to take an x-ray of it. And we can kind of double check and make sure that everything is there. So the cancer is in our specimen, the biopsy clip, that little rectangle is in our specimen. That all makes us feel better that we got the right tissue before the patient gets closed up. Okay. And now this is what it looks like in real life. This is a different type of needle, but it's the same process. On the right side, that very colorful thing, that's a specimen. That's a lumpectomy specimen, and that's an x-ray of it. Now, obviously your breast tissue is not rainbow colored, okay? This is all just dyed different colors, kind of marking its orientation in the breast. So let's say that the clip or the cancer was actually really close to like the orange side of the specimen. Then my job would be to call the operating room and I'd say, hey, the cancer is really close to the orange side. the surgeon would know, oh yeah, the orange side was the superior part of the breast. So that means I need to go and take out more of the superior margin. So it's kind of like a universal language for all of us to basically just make sure we get out all the necessary tissue in these cases. And I think that's all I have for you guys today. Looking forward to any questions or comments or anything you guys have as well too.
Still quite a few questions left.
Okay, good.
First off, a lot of the students are saying that this presentation was wonderfully done.
Oh, good.
And it'll help them a lot in their own journey towards radiology. So thank you for that. As for questions, we do have quite a few. So first off, one student was asking, so previously they were a patient, and when they got the ultrasound images back, the person who ordered them wasn't quite able to explain it as well as they wanted. So they were wondering, is it possible to just get an appointment with a radiologist?
It is. So the person who read the study obviously was a radiologist. So she said, this person's saying that it was a non-radiologist trying to explain it. Is that what
Right.
Yes.
Yeah.
Okay. Yes. So it's very simple. We actually talk directly to our patients. Oftentimes we have PCPs, let's say, will call us and be like, can you just talk, can you talk about this imaging that you read for our patient? Of course. So all you need to do is just ask your primary care, your OBG or whoever you were talking to, and be like, oh, like, can I, speak with the radiologist directly? Maybe they can help me. We do it all the time. I know at least at our institution, we do it. I know that any radiologist who's in breast imaging would be happy to kind of explain things. I think that's very useful. So that's the direction I would go in.
All right. Thank you for telling us. Another question is, these are two linked questions. What do you think are some challenges to make breast cancer screenings or mammograms more accessible to lower income groups? And how should we perhaps go about overcoming these challenges?
Well, I mean, a big part of it, is reaching certain areas, like you're saying, right? So I remember that when I think I was like interviewing or something in DC. I know that there were talks about starting up like a mammography sort of van, like mobile unit, where they'd be able to go to different neighborhoods that were not necessarily close to hospitals. That's definitely, I think, one aspect of increasing accessibility. Others, I think breast cancer, we're like lucky to be like it's studying this cancer because it does get a lot of attention, to be quite honest, with all the breast cancer awareness month, with a lot of charities and all that stuff that's kind of talking about it. Certainly after Angelina Jolie came out and said that she was BRCA positive and had some prophylactic mastectomies, that sparked a lot of discussion, I think, with patients, kind of talking to their own family members and that sort of thing. It's obviously all about awareness. We do our best to accommodate as many people as we can because we do think it's very important. But awareness is really what comes about it. And, part of my Instagram, the whole reason why I even started a professional Instagram was for this reason, to let people know the things that they should or should not worry about. Social media is one way that I've recently noticed over the last year that can provide some information or at least some awareness of the type of things that we do. The most important thing too, of course, is making sure you filter out misinformation. All right. So there's another type of imaging modality called thermography that is not really a medical technology. I mean, it's an imaging technology, but doctors do not analyze it. Radiologists do not analyze it. It's basically it's marketed as looking for breast cancer without using compression and by using heat, basically the presence of heat, with the assumption that cancers, if they're present, are going to be very hot on thermograms. So the problem is that there has been a lot of marketing, advertising, all that stuff about it. Patients who don't want to get mammograms end up getting the study, and it's not accurate. There's a lot of false negatives. So when you are looking online or reading magazines, you have to also think like, what is officially and scientifically proven? And don't just believe everything as well too, because just like there's good information out there, there's not great, there's a lot of misinformation out there as well too.
Here's a sort of a follow-up. How do you approach a situation with a patient where cost is a big issue with the procedure?
Well, to be honest, we don't deal with it as much because I know that I think it is covered generally by insurance, and we have a lot of our patients are honestly insured. It can be pricey, obviously, if you're not insured. And that's a conversation I think that we have to just have frankly with the patient because, I don't want anyone to ever think that they only want to have a biopsy if we're really certain it's a cancer, right? Like they're going to be disappointed if they shell out all this money, they get a biopsy and it turns out to be negative. I don't want anybody to ever think that's a bad experience, because that's technically a good thing. Getting that information, it's just as valuable as someone getting diagnosed with a cancer. So I think it depends on suspicion. If we have a very, 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 very low suspicion, and someone is describing to us a situation where they can't pay for something, or let's say that they're going to be out of town and not accessible to this, we may opt to do a follow-up, but that's only if we have a very low suspicion. If we have even regular suspicion or high, it's not going to change what we want to do, because anybody can get breast cancer. Now, we do have a big team, of both doctors and non-doctors as well, to a whole basically breast team that will work together with the patient to make sure that we can offer them the best care as possible. So that's kind of a long answer, because we don't deal with it directly, but I know that, as part of our team, we try to make it accessible to as many people as we can.
Dr. Chan, and on the opposite end of things, Dr. Fowler and Dr. Reno and myself, for example, are on the opposite end, where oftentimes we see patients who clearly this is a new diagnosis of what looks like breast cancer, and the patients may be completely unfunded without any type of kind of financial recourse. So what we do on the front end is we get our financial counselors involved really, really early, get them plugged into the system so that by the time it is time to get them to your team, for example, they should have the resources available to get that done.
Yes. I always think that's super important too. And those people who help with the financial aspect of things are super crucial, because oftentimes that's the biggest obstacle in getting a life-saving procedure done. So definitely.
Thank you for telling us. A couple of people have questions about COVID. So how many false breast cancer findings have been linked to COVID vaccines?
It's not really necessarily it's false. It's a false study. It's more so that we may want additional imaging for like a large lymph node. I don't think so. So the general premise is that your lymph nodes can get big but retain the same shape if it's reactive. Okay, so I think of it like this: like your lymph node is like a bean, normally shaped like a bean. Let's say you get a COVID vaccine, it may become like this, but it's still a bean. All right. When we see things like this, we aren't as worried as if your lymph node actually looked like a sphere, completely lost its shape. If we see this, regardless of whether you've gotten your vaccine or not, we're going to want to biopsy it, because that's just like a cancer sort of look. Something that is large but still retains the same shape, we're going to want to just do follow-ups for. So I wouldn't say that we've had false positives, but it has definitely increased the number of studies that we're recommending follow-up for. So the volume is definitely higher, because in that 4 to 8 weeks or whatever, we're seeing more follow-ups of lymph nodes that we usually wouldn't follow. I think, moving forward, it's probably going to change. This is just such a new thing that's happening because more and more people are getting vaccines. That being said, we are starting to treat things kind of like reactive, just like if you were to get a flu shot or whatever. And as long as we communicate with the patient as well too, that, hey, if you got your COVID vaccine, like a week before your mammogram, we're not telling you to delay it by any means, okay? But if you get called back for your lymph nodes, we don't want you to panic, because it's possible that it's related to it. And, we encounter this situation a lot because some patients have waited a very long time for their screening mammogram. They waited like all of 2020, right? Like they delayed it and now they're finally getting it. It's not right to tell them, oh, you actually got the vaccine, now you got to wait even longer. So I don't tell them that at all. But I think communicating with them, and that's something that the technologist has to do, the receptionist, like a lot of people before us have to also let people know as well too, that if you do get called back and you're asked to get an ultrasound of your armpit area to look at lymph nodes, don't necessarily panic. We will find out, whether this is reactive versus something we need to biopsy. So that communication is important, I think.
Thank you for clarifying that. You mentioned that a lot of people have been waiting like all of 2020. So would you say that there's a decrease in screenings because of COVID?
There was in 2020 for sure. It took a really long time for any institution to not do screening mammograms because I mean, it's a really big deal because we know that screening mammograms like save lives. So to remotely delay them is a huge issue. That being said, the pandemic was like this crazy, unusual time, and we really had to have people weigh the risks and benefits, right, of coming into a public place, which is technically very clean. We're all wearing masks and stuff, but it's a different environment that you're home. So you have to weigh that risk versus the benefit of getting your mammogram. Unfortunately, a lot of people delayed mammograms during that time, just like screening colonoscopies. I've heard that from my GI friends. We still did a lot of procedures during the time. So people that had suspicious findings, we still did all of the biopsies during 2020. I would say, between like the first and the second wave, more people came in, then the second wave came, and then less people came. Ultimately, we're pretty much back at normal / still trying to do some catch up. And only time is going to really tell what was delayed because of this. But like I said, it was all kind of risk benefit, we don't want, 70-year-old women who have COPD and all these other issues who aren't vaccinated to come in and get a screening mammogram when that acute risk of getting COVID was so much higher, let's say, than getting a breast cancer. But of course, we always gave patients the option of coming in. Things did get delayed though, for sure.
Good to know. Some more questions. So once you do catch a malignant lump pretty early in the screening, what's the typical treatment there? Do you resort to chemo or do you just excise it out? What do you guys do?
So it depends. Generally, they're always going to see a surgeon. Okay. A surgeon's always going to be involved. And if it's a high risk lesion, they may talk to them about doing a follow-up versus actually excising it. For all invasive malignancies, the ones with the word invasive in it, or DCIS, they're going to need a surgeon. Depending on the subtype, sometimes there might be chemoradiation as well too. So in all of our conferences where we discuss these patients, there's usually medical oncologists, the ones who deal with chemotherapy, and there's also radiation oncologists as well too who deal with radiation. So it's kind of like a group effort. It depends on the subtype. It depends on whether it's involved in other areas. So you could be like lucky in the sense that you only have one area that's affected. Some less lucky people may have two sites that are affected, but it's only in one breast. Or it could be two sites, but one is in the other breast, So that all kind of plays a role into what kind of treatment somebody gets. But it's going to be involving these folks basically.
Thank you for telling us. Another question. This is about transgender patients. Two questions that we have. Do you see a substantial number of transgender patients? And do they tend to have unique concerns? And also, would you say that there's additional training education necessary to consider a transgender patient?
So we don't see that many. Obviously, we are aware that, we have this patient group. Some things that, I think are, I think we did have a patient that was transgender coming in for a breast ultrasound. So anybody that's like on not hormone replacement, but hormone therapy, is going to develop, let's say, like breast cysts. That's always a possible thing. So in that one patient, I remember it was a male to female, and she had breast cysts, much like a female would. Unfortunately, I believe they would be, more prone to cancers and that sort of thing as well, because I think that their therapy is, it obviously has estrogen in it. There's not necessarily different imaging that we do because we just don't see it enough. However, if we know that somebody has been on that sort of medication, we kind of treat it as if like they had naturally occurring estrogen, like any other female. We don't really treat it very differently. In terms of training, I believe that I feel like I heard about maybe one of our surgical fellowships or maybe one of our endocrine fellowships having like a transgender component to it. For us, I think, we have guidelines that are coming out, every month or every year that's going to better delineate what we need to do. But I don't think it's going to really change what we do as much. We just have to be aware that if somebody has been on hormone therapy, that we just need to be more cognizant of the breast cancers that we can catch.
I love the multidisciplinary approach to transgender care. It's really revolutionized the way we see these folks and we treat these individuals. So it's going to be amazing to see kind of how medicine um, going to adjust itself and takes care of these patients as they should.
Definitely.
So we have another question for this is for male patients. Is there any stigma that comes with male breast cancer? And so how has breast radiology education evolved to ensure males that are aware of the risk and that they follow whatever types of screening that they may need?
Well, it's interesting. So men, in general, don't like coming to see us. So that can be good and bad. In the sense that like sometimes by the time we see a mass, it's generally more pronounced than in a female, right? Who has like a lower threshold for coming to see us. So that can obviously be an issue. More often than not, we see a lot of gynecomastia. So that benign breast tissue that we see, and that's because it causes a lot of discomfort around the nipple area. It's basically like periareolar soreness, and that can be very bothersome for people. So I think that if the symptoms are like bad enough, male patients will come to see us. They're seated in a different area, in a different waiting room, as opposed to being in the regular waiting room with our female patients. We don't have any stigma towards them. We know that breast cancer can happen in men. We know that lymphoma can happen in men. So if a man comes in with an axillary node, for instance, and has a history of, let's say, breast cancer in their family, we're going to treat it just like we do anybody else. I think the most important thing is that in those cases that we discuss with them the causes of gynecomastia, whether it's just with age or it's with marijuana use, certain medications. That always helps kind of clarify the answers for them. But we do see a good number of male patients, and I think maybe they feel a little bit awkward, but it's okay. I mean, we're still all physicians, and technically, this area can be, I guess we use the word chest a little bit more than breast. I guess that's one thing that we kind of do a little bit differently. At least I try to say that, even that like terminology, I think can make someone feel a little bit better about being there.
That's interesting to learn. One more question. How often are conditions misdiagnosed in radiology, would you say?
Misdiagnosed, like completely missed, or
either that or just like they got the wrong type of disease or something?
Well, I would like to think is low. Obviously, with screening in my field in particular, a cancer can technically have been there on a screening mammogram the year before, but it was so small, so subtle that it just was not picked up on. Okay. And the reason why we wouldn't like pick up on that is because we can't call every single patient back. If we did, there'd be no point in screening, right? Like there's got to be ones where we say, hey, like, this is going to be fine. And then we kind of like cherry pick the ones that we're most worried about. So in those sense, it's kind of a weird term to be like, hey, we missed that cancer. So we have to look back at those old pictures and be like, would anybody really have been concerned about this at that stage? If not, it got caught at the stage that the imaging was most abnormal, or least abnormal enough to be detected. Now, in the other side of things, when you're reading, let's say for the emergency room, it's really crucial that we don't miss, let's say, an aortic injury. Those are all really, really important things, or like a fracture or something like that. So we try to decrease as much as we can. It obviously happens, but that's what our training is for, to really decrease our misses.
And everything is mitigated by, just like every other specialty, with ongoing continuing quality improvement. Same as in emergency medicine, such as every specialty. Yeah, absolutely. We're human, but the most important part is what we learn from it, what we can do about it, and institute processes to ensure it occurs less often.
We do, radiologists in general, I think, are very good at showing each other cases and not being judgmental. Because it happens to all of us, but that's how you really learn. It's peer review. So we show each other cases that may not be necessarily ours, or could be ours. Either one's fair game, but we learn from it. And sometimes, let's say that we do have a miss, we're really going to remember it so that the next time we're like on alert for these kind of findings. It's always an evolving practice. It's always about learning, but that's what peer review and these other sorts of things are for. And I'm lucky that, in radiology, the culture is that it's very non-judgmental, because radiology is tough. You can never really, there are things that can be blatantly missed, okay, but in general, it's usually subtle things that are missed. So we kind of show each other to prevent any other issues.
Thank you for saying all that. One last question from me. Can implants cause inflammation if ruptured? I know you talked about the saline implants. The saline will generally get resorbed by the body. So for silicone implants, would they potentially cause inflammation if they rupture?
It's not necessarily inflammation, but it's fibrosis. So things get really like tough around these areas. And you can tell that this happens because in other countries / back in the day before implants were invented, people would get silicone injections. And that's literally like a non-doctor injecting silicone into random parts of your breast for the same purpose, for augmentation. The problem with each of these little pockets of silicone is that the breast tissue around it eventually fibroses. It gets really thick, and then you can't see anything on imaging. It's actually really tough to read mammograms and ultrasounds on these people. So it does cause a reaction of the tissue around it, but I wouldn't say it's fibrosis. It's just what happens when you have any kind of foreign body. Technically, when you have an implant and it's like perfect, not ruptured, you do get like a capsule that forms around it. So there's kind of like a consequence to it if it was to rupture, but more so if there were big globs of silicone that are actually leaking out / put in there intentionally by a syringe.
Thank you for a wonderful presentation. Dr. Fowler, do you have any more questions to ask?
Okay, I got unmuted. I couldn't unmute there for a moment. Tiff, what a wonderful presentation. We're blessed here at UT Southwestern that our pediatric radiologists have sessions twice a week for about 15 or 20 minutes, and we go over very interesting cases that we've had from the emergency department. And Tiff, I am astonished at the intricate level of anatomical knowledge that radiologists have. And I want to ask you, how do you keep all that stuff in your head?
Well, yeah, it's actually really, really difficult. I mean, that's kind of the reason why our residency was so long, to be honest. And that's why when you want to be a specialist in, let's say, pediatrics or musculoskeletal or whatever, you take that additional year and you really, really learn it well. We do have a lot of sources online, obviously, that help us learn. But all of it's going to be image guided and just seeing it over and over and over again. A lot of the times is not even just what you read in the books, is what you're seeing in the reading room every day. You start noticing that this artery always looks like it's kind of like this, or, this organ always has this kind of familiar look. So a lot of it is just with practice as well, too. Starting with pediatrics, it can be tough because different organs and structures are looking different at different stages, right? Like based on the age and everything. So that's definitely one field where anatomy is super important at different stages. It is tough, but I don't know, it's pretty fun, to be honest, to know like what's inside. That's what kind of stirred my interest in the first place.
So Tiff, you've had upwards of 14 years of training. How did you not burn out during that period? If this has been asked before, I apologize, but I'm just curious.
I mean, I guess I've always been a little bit more of like a positive sort of person. I saw the light at the end of the tunnel. I had a very good support network. A lot of my very good friends were suffering along with me, which kind of makes it, a little bit better because you kind of can like gripe together. And when you're stressed out, you see they're stressed out as well too. And you're like, okay, that's like totally fine. I think that's a big part of it, and I wanted to get things done with. Like I knew I wanted to be a doctor. I knew I wanted to go into radiology. So I never really had a wavering of like, is this the right field for me? I think that, having good mentors is a big part of it too. Mentors that you can relate to, that have graduated more recently, that can basically say, hey, like, things will be okay. It's just for now, just get through this obstacle and you'll be fine. I think those were all kind of big parts of that for me where I didn't burn out. I was lucky though. I mean, everyone's different, so.
Having mentors is such an important part of this process of survival in education. The mentors are people that, number one, befriend you because they care about you.
Right.
Number two, they have a genuine interest in you as a future healthcare provider. And number three, we steal ideas from mentors very freely. They help us with ways to think about things. And I think all of us have had folks that along the way we've stolen ideas from very freely. Gil Salazar is one of the finest clinicians I've ever seen, and I love crossing paths with him in the emergency department because he thinks about things in new, informed, and novel ways. And I go, gosh, I'm learning all this stuff from a younger guy. So very, very important. Well, Tiff, this has been a terrific presentation. We had oodles of folks writing into chat saying, what a wonderful PowerPoint presentation. You are a PowerPoint geek, which among us geeks is a high compliment.
Thank you. I appreciate it.
Very, very, very beautifully done, Tiff. So just thank you so much. And I would like everybody, the over 300 still online, please say thank you, Dr. Chan. Let's have those thank yous. Look at the chat going by, Tiff, just to look at all those people who just we're sitting on the edges of their chairs, listening to this wonderful presentation. Tiff, We've reached over 1,000 universities in 28 nations. We've had over 50,000 folks sign up at the website. And so virtual shadowing has offered a lot to healthcare providers all over the world. And tonight you have been one of the stars of our entire year of presentations. I like to say in closing that, of the, oh golly, we'll probably have 5,000 people watch this presentation, over 400 live tonight. About 5,000 will watch it. Each one of those providers will see 100,000 patients in a lifetime, in a career. 5,000 times 100,000 is 500 million. Tiff, tonight you've touched 500 million lives, and we just thank you so much for your kindness, your warmth, and your amazing professionalism. So thank you so very much. All right, virtual shadowing folks, it's good to have you back. We're going to be here if you keep coming. We're coming up on a year of doing this, and please let us know if you want us to keep coming back week after week, because we'll be here if you want us. So, all right, everybody. Well, what a great evening. Dr. Salazar, Dr. Reno, the whole virtual shadowing team, the amazing Dr. Chan. Do we have the quiz information, Rohit?
Yes, just on the next slide.
All right, please.
So here's the quiz information. You'll have until next week's session to complete the quiz. As usual, you'll have 2 attempts to get above a 70%. And once you've completed it, please be sure to download the certificate. Here's the QR code on the right. You can scan this with your phone to get the quiz, and we'll also provide a link in our weekly emails.
Great. Thank you so much for having me, guys. What a great opportunity. I'm so glad you guys are doing this. Thank you.
Well, and thank you, Tiff. Thank you, Gil. Thank you, Dr. Reno, and the whole virtual shadowing team. We thank you all for coming tonight. And on behalf of the whole virtual shadowing team, we wish you a good evening and a good night.